Good afternoon or evening and welcome. Kensington Senior Living has 7 unique communities, 4 located in Virginia, Maryland, and New York, and 3 sister communities located in California. Kensington is truly privileged to support care partners and professionals from coast to coast. Kensington focuses on relationship-based care built on the foundation of our promise to love and care for your family as we do your own. That promise was what initially drew me to become a member of the Kensington family, as my father lived at Kensington for almost 7 years. It is programs such as the one you are attending now that are so important for those of us walking through a caregiving journey to hear from expert professionals on keeping us current with the latest advances in care management and treatment of conditions that affect seniors and their families. Today's webinar will be sent to you via email to everybody that registered for you to share with friends and family. So no reason to take notes, and please listen as our experts share with you today. Today, you're in for a treat is Dr. Armen Moughamian, Director, Ray Dolby Brain Health Center, Lauren Liesem, Vice President, Institute on Aging, and Alexandra Kaplan, Caregiving Coach with the Institute on Aging. We'll discuss early detection and the promise for new treatments of Alzheimer's disease. Thank you for joining us. It's a nice day in San Francisco.
Actually, it's a very nice day. Thank you so much for having me. I'm Dr. Armen Moughamian. I'm a cognitive neurologist here based out of San Francisco. I'm super excited to talk with you guys today. Just going to share my screen and start my presentation. So yeah, I'm the medical director of the Ray Dolby Brain Health Center, which is a cognitive neurology practice based out of San Francisco. I'd like to start by introducing myself, what I do. So I'm a neurologist by training, and I did a subspecialty training in cognitive neurology, and I've been at the Ray Dolby Brain Health Center for about 3.5 going on 4 years. It's a very special place to be a clinician and to provide care, very much similar to what Susan just said. We truly believe in that the caregiver is incredibly important. And so we are a philanthropically funded clinic that came out of the experience of the Dolby family with Alzheimer's disease and dementia, where we provide comprehensive patient-centered care to patients and families dealing with cognitive impairment and dementia. And so we, from the very beginning, really try to prioritize both the patient, but also the family, because we realize that the need for that family member to help patients through this process. And we provide diagnosis, treatment, education, and psychosocial support throughout the entire course of the disease. We're based here out of San Francisco, as I said, and we're part of the larger Sutter Health network that ranges clinics all the way from Northern California, north of Sacramento, to as far south as Sacramento and into the Central Valley, such as Modesto. And we're one of the tertiary referral centers for people with memory disorders that are based in the Sutter Health system. One of the key parts of our model of care is the combination of both a provider, doctor or nurse practitioner, with a social worker from the beginning. So we have this dyad approach, which really follows the patients through the entirety of their journey with cognitive impairment. We also provide access to biomarkers and neuropsych testing, as well as clinical trials. We're a site for multiple clinical trials, which trying to give patients access to earliest treatments as possible. So just want to introduce myself, what I do, but the majority of the talk today is going to be about the importance of early detection for Alzheimer's disease and new therapies along the horizon, and those that have actually been approved, which can slow the disease down. Okay. Few disclosures. I have consulted for companies that are involved in the development of new therapies. We do research trials here at the clinic that are sponsored by pharma companies, but this is not a sponsored program at all. And all the data that I'm presenting here are publicly available. The goal of this talk, number one, I mean, it's not even actually on here, but really the goal of this talk is to provide you guys an understanding of what these new therapies are. I see the job as a clinician to really open the door so that patients and families can make the decision that best fits for them. The goal is not to put people onto therapy or create barriers, but really to just create a conversation and allow you to make the decisions that are best appropriate for what you value in your care and in your life. And important to that is developing an understanding of what these medicines are, where they appropriate, the difference between the stage of the disease and the actual disease, such as Alzheimer's disease. Appreciating a little bit of the early signs of the disease, and then we're going to talk about lecanemab. We'll talk about the efficacy, the safety, the monitoring that's required, as well as the administration. And lecanemab was approved by the FDA in July of this year. The first medication to be fully approved by the FDA that actually slows the progression of Alzheimer's disease down and addresses the underlying pathology of the disease. Okay. So what is cognition, right? So cognition is more than memory. Everybody that not everybody, but a lot of people that walk into our clinic say, oh, I have a memory problem, doc. Well, memory is a lot of different things. And memory, what I think of as a cognitive, right? And there's many different domains of cognition. So for me, memory is learning, memory is recall of recent events or long-term events, short-term, long-term memory. There's also executive difficulties. So concentration, multitasking, attention, judgment, decision-making. Visuospatial, are you driving? Are you getting lost? Are you having difficulty using tools or recognizing people? How about language? Are you having word finding difficulties, difficulties with comprehension, or changes in mood? And the important thing here is that because cognition is more than memory, you have to recognize that changes in any of these cognitive domains could be concerning for a neurodegenerative disease such as Alzheimer's disease. And so it's really important to recognize that it's more than just memory. Alzheimer's disease is not just memory. It's a disease that affects a lot of different areas of the brain. And so it's important to, yes, you can have short-term memory problems, but you can also have difficulties in some of these different areas. And so it's important to recognize that so you can think about what an early referral would look like. Okay. And when we talk about the stages of cognitive impairment, it's actually a process that takes 15 to 20 years to develop, okay? And dementia is really the last stages of the disease. So in the earliest stages of Alzheimer's disease or of a cognitive impairment, you're really just getting pathology accumulating in the brain. Hasn't done much yet, but it's accumulating. Then patients enter a subjective cognitive impairment. And this is some patients enter this, some patients don't. And this is where they feel a little bit off, but when we can't actually detect anything when we give you objective cognitive measures like cognitive tests. The next stage is a mild cognitive impairment. And a mild cognitive impairment is three different things. One, there's some symptoms of cognitive change, which either the patient recognizes or the caregiver recognizes. Two, we can demonstrate that on objective measures of cognition, things as simple as an in-office test to more complicated neuropsychological measures. But most importantly, it's not having a functional impact on the patient. The patient is still doing all of their instrumental activities of daily living, finances, driving, medications. They're still taking care of themselves in all as they did previously. They may be more reliant on a calendar. They may be more reliant on notes and reminders, but they're still doing it. They're adapting around the cognitive change. And that distinguishes from a dementia. Dementia is when the cognitive impairment has progressed to the point that it starts to impact function. So dementia can be divided further into a mild dementia, moderate dementia, and severe dementia, depending on the level of impairment on a patient's function. So in the mild stages, a mild dementia means that they need assistance with instrumental activities of daily living, which I've defined up in the upper right-hand corner. So that's when it becomes harder to manage their calendar. It becomes harder to manage their medications. They may need some reminders. They need somebody to fill a pill box for them. They may not be paying bills as well as they did previously. That stage can last for many, many years. Then patients start to get into a moderate stage dementia where they may need some prompting for dressing, changing their clothes, reminders for grooming. And a severe dementia is when patients have full dependence. Usually these patients may need to usually need daily care, caregiver most of the day, if not all day. When we talk about these new medications for Alzheimer's disease, specifically lecanemab, we're looking at what we define as an early stage of Alzheimer's disease, which is a mild cognitive impairment to an early stage of mild dementia. So that's why I'm really highlighting this in the middle here, mild cognitive impairment to early mild dementia. So no functional impairment to early difficulties, little bit of difficulties with some function, okay? Mild cognitive impairment is mild, all right? The word is in there on purpose. These are very subtle changes in cognition. And most patients, when families say, oh, my patient's doing fine, that's by definition, mild cognitive impairment is mild. And these are super subtle changes, just a little bit of forgetfulness, a little bit of difficulties with word finding, maybe a little bit more difficulties organizing paperwork that you did previously, maybe a little bit of change in your mood, a little more anxiety, a little bit more depression. But again, you're managing life as you would have. It's just a little bit different than what it was previously. So it's important to recognize that very early changes can be mild cognitive impairment. Now, it may not be due to Alzheimer's disease, but I think it's important to recognize it, and you can get it evaluated. And there's a distinction between the stage of the cognitive impairment and the cause of the cognitive impairment. So not everybody that has a mild cognitive impairment is due to Alzheimer's disease. It could be to other neurodegenerative disorders like Parkinson's disease or frontotemporal dementia, or non-degenerative causes. Maybe you're not sleeping as well. Maybe you have anxiety. Maybe you have sleep apnea. Okay, so mild cognitive impairment can be due to a lot of different things, as can actually a mild dementia. The further along you go in this process, it tends to look, it most likely is neurodegenerative. But it's important to recognize that not everybody that has a mild cognitive impairment is due to Alzheimer's disease or a degenerative disease. And so many of these things are treatable. And what I'm excited to tell you about today is that Alzheimer's disease has a new therapy, which we actually can slow the progression down. Okay. So what is Alzheimer's disease? Alzheimer's disease is a pathology. Alzheimer's disease is the accumulation of abnormal proteins in the brain. This is characterized by this graph here on the right. In the earliest stages of Alzheimer's disease, there's an accumulation of a protein called amyloid in the brain. That's highlighted here by two different measures, purple and red, that are one by spinal fluid, one by imaging. But you see that amyloid accumulates very early in Alzheimer's disease. And then you get the development of a second pathology in the brain called tau. Tau is the second one, that's the light blue line here. Then you start to get structural changes in the brain, which lead to the symptoms of cognitive impairment, okay? So it's a process. Amyloid leads to tau, leads to neurodegeneration and changes in the structure of the brain, which lead to the cognitive symptoms. So that Alzheimer's disease is defined by these accumulation of abnormal proteins, which we can actually measure in the spinal fluid or by imaging in the brain. By the time somebody comes to my clinic, these pathologies have accumulated over a number of years. This whole process takes that 10, 20-year process from start to finish. This is a very long duration illness. Now I'm going to transition into treatments for Alzheimer's disease. So this graph is a caricature of how this disease progresses over time. Okay, yellow line is let's say Alzheimer's disease, where there's a slow change in function, cognition, quality of life over time. The therapies that we've had for Alzheimer's disease previously, things like donepezil, rivastigmine, memantine, what they do is they do what the red line shows. Okay, they show when you start somebody on treatment, you get a slight boost in function and cognition, but you follow the same trajectory over time. So it creates a parallel line that's above the original trajectory. They have modest benefit, but they don't change the underlying trajectory of the disease. The new therapies that I'm going to talk about are not do not cure the disease. They don't stop the disease progression. Cure would be kind of reverting towards up. Stopping progression would be the green line here, which is a full sort of arresting of change over time. But what they do is they result in a slowing of the decline over time. They're the blue line, where they're actually modifying the slope of the disease and resulting in a slowing of progression over time. And both symptomatic therapies and disease-modifying therapies can actually be combined. That's not written out on this graph, but it's the lecanemab, which is what I'm going to talk about for the remainder of the talk, is the first medication that's actually approved by the FDA to actually slow the progression down where we're seeing a slow change in the slope of the progression over time. So this is the data that got the medication approved. So the medication is called lecanemab. It runs by the brand name Leqembi. And what it does is it slows cognitive decline by on the primary measure, the CDR sum of boxes, which is a standard measure, is about a 27% slowing that was measured by 18 months. But you can at 18 months. And you can see on this graph here that there's divergence over time. So that's the disease modifying, the slowing of cognitive impairment over time. There were many different measures that are listed here on the right. Some showed 26%, some showed 37% slowing. On average, when I talk to my patients about lecanemab, I say you're looking at about a 30% slowing of cognitive decline at 18 months. The trial was done over that period of time. We don't know actually what will happen after 18 months. There is some suggestion that because it's changing the underlying biology of the disease, that this might actually diverge more over time. We don't know that though, because the trial was done at this defined period of time, and the endpoint was that 18-month period. This was a very well done clinical trial that included nearly 1,800 patients in that early stage of Alzheimer's disease. Everybody was proven to have amyloid in the brain via a PET scan or spinal fluid measures, and they were in that early stage of mild cognitive impairment to early mild dementia due to Alzheimer's disease. It was an IV infusion that lasted every 2 weeks, and again, resulted in approximately a 30% slowing on this measure. That's a hard thing to conceptualize. What does 30% slowing mean? And this graph, I think, is a very, very helpful graph when understanding that you're not only talking about 30% slowing, but you're talking about a 30% slowed risk in converting to the next stage of the disease. So as I told you, you can start in this trial as either mild cognitive impairment or a mild dementia. And those that were treated with lecanemab over every 2 weeks, IV infusion over a year and a half, had a 30% less patients converted to the next stage of the disease, which means that if you started with a mild cognitive impairment, 30% less patients had a significant enough functional impairment where they now required somebody to help them with their finances, their medications, their appointments, driving. So this medication is prolonging the stage that patients entered in with the disease. Or if they entered into mild dementia, it prolonged the time in mild dementia and reduced the number of patients that converted to that next stage of disease. Where if you go from a mild dementia to a moderate dementia, that's now requiring some assistance with activities of daily living, prompting for bathing and dressing. So 30% slowing of that in that conversion is, I think, a very meaningful slowing of cognitive impairment for patients. Preserving time in a more mild stage of the disease where they can have a better quality of life and preserved function. And the point of preserving function is preserving autonomy. I think that's one of the major issues with the dementia, is that as the disease progresses, it takes away your function and it takes away autonomy, which is what patients really value. And the goal of this therapy is to preserve patients at an earlier stage. But by no means is this a cure. It's just a slowing of the cognitive impairment over time. Another important measure is, what does this mean? How did patients, we can measure it on pen and paper tests. We can measure it on what caregivers report for how they see them interacting daily life. But what do patients and caregivers internalize as their quality of life? What are the health-related outcomes? So this is a variety of different graphs which speak to that. So this EQ5D5L is a European measure that looks at quality of life. And what we see is that patients on lecanemab, the green line, had report less changes in their quality of life. Again, it didn't improve their quality of life, but they showed less slowing of declines in quality of life. Similarly, the Zaret Burden interview is an interview of the caregiver. And this is a well-validated measure. We interviewed the caregiver in the clinical trial, and what the caregiver shows is that there's less burden, less decline that they're observing, and less burden of the care that they're providing. And it's by about, a 30–40% slowing of the burden on the caregiver. So you're not only talking about the patient's slowing of cognitive impairment, you're talking about less burden on the caregiver and more quality of life for the patient themselves. The quality of life AD, roughly similar to the quality of life, the EQ 5D 5L, and these are both observed by the patient and their proxy or their caregiver. I show all this data to say that patients and caregivers are on therapy are observing less impact on their quality of life. Again, modestly, it's not a cure, but it is a modest change. And the first time we're really seeing this type of change in the quality of life that patients observe. Safety is incredibly important. So there are two main safety risks associated with lecanemab. And we can talk more about this in the question and answer, but I'll put it out there, right? So the first one is an infusion-related reaction. This is really an allergy to the medicine. So as patients are infused with this medication, it can result in an allergy, which often results in flu-like symptoms, fever, chills, muscle soreness. They typically resolve within 24 hours. About 1/4 of patients experience one of these side effects, and they were all pretty much in the mild range. And they all occurred in the first few treatments. So probably within the first 3 treatments, rarely after that, they had some of these mild infusion-related reactions. What we've now been doing is treating patients with Tylenol and a Zyrtec prior to their treatment. And that's really helping helping patients to have less of this flu-like symptoms after the infusion. Rarely, there were some pretty severe reactions where people had blood pressure drops, they needed some resuscitation, they had an anaphylactic reaction a few hours after the infusion. To sort of come back, to be able to monitor patients for this, even though it's quite rare, we are infusing patients. And then for those first 3 infusions, we're doing an extended monitoring period of time. So patients are undergoing a 3-hour post-infusion monitoring for the first infusion. Then after the second and third infusions, they're getting monitored for 2 hours. And then after that, they can pretty much go home right after. Each infusion lasts 1 hour. So again, an IV infusion every 2 weeks for 1 hour. First infusions require some post-infusion monitoring. The rest of the infusions should be monitored for about 30 minutes, but that's pretty much the time it's going to take for them to get the IV out and get you out the door. The other major side effect, which is probably what a lot of you have read about, is a side effect called ARIA. It's an acronym that stands for amyloid-related imaging abnormalities. This is the swelling that can happen and the blood that can happen, which is what a lot of press was given about. Okay, ARIA comes in 2 forms. There's ARIA-E, which is the edema, which is a swelling, and ARIA-H, which is little small bits of blood. Sounds very scary, I get it. And what happens is that as this medicine works, so lecanemab is an antibody that removes amyloid from the brain. As the medication is working, it stimulates the immune system, and that can result in swelling. It's actually, the side effect is the medicine in many ways working. So the overall risk for ARIA is about 20%, 21%. ARIA also occurred in the placebo at 9 to 10%. The ARIA that occurred in the placebo is pretty much ARIA-H, that these little bits of blood can happen in patients with Alzheimer's disease. And really the treatment-related effect was ARIA-E, the swelling, which sometimes could occur with ARIA-H. So it's ARIA-E plus ARIA-E, ARIA-E plus ARIA-H. The ARIA occurs, 92% of the ARIA occurs in the first 6 months of treatment. Again, it's because the amyloid is being removed from the brain, so as this medicine is working, the amyloid-related imaging abnormalities, the ARIA can occur, almost all within the first 6 months of treatment. 75% of ARIA is actually asymptomatic. So the majority of patients that experienced ARIA, it was only seen on imaging. This requires the monitoring, which is what I'm going to talk about next. Those patients that did get symptoms, there were 6 symptoms that could happen: headache, nausea, dizziness, vision changes, confusion, or walking changes. These symptoms, if they occurred, can last for some time, a couple of days to weeks, sometimes even up to a month or two, but resolve by holding the medicine. Rarely did patients have persistent side effects, but they do resolve over the course of a couple of weeks to months. That the symptoms resolve first, then the imaging resolves as the inflammation comes down. It is very important to note, though, that there were 3 reported deaths in the clinical trial of 1,800 patients due to the ARIA side effect. One of these patients was on an anticoagulant, a blood thinner, received a blood thinner, and then had a hemorrhage, and that was fatal. So other blood thinners are things like Coumadin, also known as warfarin, rivaroxaban, known as Xarelto, apixaban, known as Eliquis. These are blood thinners. So our recommendation is to not be on a blood thinner if you're going to go on to lecanemab, especially in that first 6 months of treatment. The other patient that died, one of the other patients that died, was experiencing stroke-like symptoms and received a clot-busting medication called TPA, and that resulted in a hemorrhage. So we do not recommend that patients that are on lecanemab receive thrombolytics, again, clot-busting medicines, if they were to have a stroke. You could get the clot removed if possible, but you should not, under nearly all circumstances, receive a clot-busting medication. The risk of ARIA is not uniform across all patients. And there's a gene called the ApoE gene, which can be tested for, which helps us stratify the risk of ARIA. ApoE gene we know about is also increases the risk of Alzheimer's disease, but it also increases the risk of ARIA. If you are in the low risk group, which is the majority of patients, majority of the population is E3, E3. It's around a 5% risk of ARIA and a 1% risk of it being symptomatic. If you have 1 copy of the E4 gene, which is around 15% of the general population, it was about 50% of the clinical trial, you have about a 10 to 11% risk of ARIA. 2% of those patients became symptomatic. If you have 2 copies of the E4 gene, the risk goes up significantly, and it's around a 1/3 risk of ARIA, and about 10% of those patients became symptomatic. So I recommend that all patients undergo ApoE gene testing to be able to understand what going in eyes wide open, are you in that higher risk group? You may still decide to go on the medication, which is fine, but you'll understand your risk. You may require additional monitoring, although the guidance from the FDA is not necessarily to do more monitoring, but that's a doctor-to-doctor conversation. So let's talk a little bit more about now the administration of the medication. So as I said a couple of times already, the medication is IV, so you'll get an IV placed. You'll go to an infusion center, typically. It's infused over 1 hour. The additional monitoring is necessary. It's done every 2 weeks. It's a big commitment, right? This medicine is not a simple medicine to give. It's not a simple medicine to receive as a patient. It requires this commitment from the patient and the family to going to the infusion centers and getting their monitorings and the necessary monitoring. It's every 2 weeks for 18 months. So you're thinking about 36 infusions. After 36 infusions, it's a little bit debated about how patients will go off therapy or transition to a different type version of this therapy. That will be determined over the next 6 months to a year. There's actually data going to be released in a couple of weeks that's going to help us with that. But going into this, you're thinking, I'm going to do this for 36 infusions. Now, if something goes wrong or you get a side effect, you can always stop. But I think the duration of therapy should be, you should think, I'm going to do this for 1.5 years. Lecanemab is in addition to symptomatic therapies that patients are already on. Over 50% of patients were on medicines like donepezil or rivastigmine, the rivastigmine patch, memantine. Patients were on those therapies, so this is an add-on therapy to that. It's not in replacement of that. Patients should have an MRI within 1 year of initiating treatment. This is a safety factor to make sure that nothing has developed in the brain that would preclude them from getting the treatment. And they need to undergo 3 MRIs in the first 6 months of treatment. This is because 75% of patients with ARIA, the side effect of lecanemab, had asymptomatic side effect. And we don't want to keep giving patients that medicine and then that becomes symptomatic. And so patients have to undergo an MRI between the 4th and 5th infusion. That's around 2 months into treatment. Between the 5th and 6th infusion, that's about 3 months into treatment. And then at 6 months of treatment, which is between the 13th and 14th infusions. And then if they got any other symptoms that were concerning for ARIA, again, headache, nausea, dizziness, vision changes, walking changes, or confusion, then you may need to undergo additional MRIs to assess for ARIA. As far as insurance coverage, right now, Medicare is paying for this. They cover 80% of the cost of a medication, and then supplementals cover the remainder. So some patients have Medicare as their primary with a supplemental. Those are tending to get paid for. You may have to undergo a deductible or a co-insurance. That's dependent on each individual plan. The Medicare Advantage and commercial insurance are a little bit more complicated. They often require authorizations, but these are getting paid for, and we have a number of patients with Medicare Advantage plans that are getting it paid for. Every patient that's a Medicare eligible patient should be enrolled in a registry. This is something that the doctors do. Doesn't really involve much for the patients. There are some more complex registries that are coming out there called, like, for example, ALZnet, which we're going to be participating in, that may require some consent to be able to send more information. But the current very simple CMS registry doesn't require any effort on the patient standpoint. It's just something the doctor has to do to allow Medicare to pay for the medication. This is just a reminder about safety, really avoiding anticoagulation. Would not recommend it in patients, and we would not, in the rare setting of an acute stroke, I would not recommend that any patient receives thrombolytic medications such as TPA or TNK. That's largely what I had to do. I do want to add one thing, because there was a question that started early on, is why are these medicines all of a sudden working? So it's a great question. And I'd like to say that, clinical trials are an iterative process. So there have been anti-amyloid therapies that have been developed probably around the past 20 years. And there have been numerous failures in the approach. And each of these clinical trials, we have learned something. We've learned about targeting different species of amyloid, how to make different antibodies that actually stimulate the immune system to remove amyloid. We've learned that we have to include patients with an amyloid scan and biomarkers. I didn't cover that a lot today, but it's incredibly important that every patient that goes or is considering lecanemab have a confirmatory test to prove whether or not they actually have amyloid pathology in the brain. And the initial clinical trials that we did on anti-amyloid therapies, not lecanemab, but a different one, didn't actually include that. And so we were putting patients in these clinical trials that didn't actually have Alzheimer's disease. We also learned about better dosing and earlier stage of the disease, this early mild cognitive to mild dementia. So these clinical trials that were not necessarily failures, there were learning opportunities that have allowed us to get to the point where we have lecanemab. There's also another medication called donanemab, which will be, I suspect, is going to the FDA, and it has a good chance of being approved kind of early 2024. And now these therapies are working because of everything that we have learned over the past 2 decades of treatments with Alzheimer's disease, specifically with anti-amyloid therapies. So I do think that this is a step forward. Again, it's not a cure, but I think it's a big step forward.
Before you leave us, I just want to make a couple comments. And one is, I am so impressed with Sutter Health and Dolby Memory with your multidisciplinary approach to really care for the whole patient. And I will underscore patient and family. And our ladies that I'm about to introduce from the Institute on Aging would agree with me. And there was actually a comment in the Q&A that I will share now before I introduce them. It says that they call you Dr. M, has provided the most concise, simple explanation and many things cognition I have ever seen as a social worker who works with dementia patients. Wonderful. So thank you for that, because we all know navigating clinical care can be frightening, and to really support the whole family through that process, I just think is such a gift. And then I just want to underscore one more thing. As you know, you can join us, Laura. Go ahead and come on, Alexandra. But the 30% slowing is so important for someone that's in this journey with Alzheimer's. My father passed from Alzheimer's, but I think another underscore is the 30% decline or for the next stage, because we all know with Alzheimer's, it's all of a sudden like one day you go, oh, it really is a steep drop. And I think that is so encouraging. So thank you. I will see you for the Q&A, and people are already,
I'll go in the
I see
background.
a bunch of people asking questions, which is great. But next, I'm thrilled and honored to introduce these ladies, Lauren Liesem and Alexandra Kaplan from the Institute on Aging, because we all know that in this journey with Alzheimer's or dementia, there's a clinical aspect, but even more importantly, there's a caregiving aspect. Because of all the 7 million people that have a diagnosis with Alzheimer's in the country, there's an average of 5 caregivers, 35 million people in our country. So thank you for what you do. And I'm going to leave it to you, and I'll see you when you're done, and then we'll do the Q&A. Thanks.
Excellent. Thank you. My name is Laura Liesem. I'm the Vice President of Central Operations at Institute on Aging, and I'm also a licensed clinical social worker. We are incredibly grateful to partner with Dr. Moughamian and his team. We frequently receive referrals. We're great collaborators. And as you've all witnessed today, he is brilliant and shares his knowledge very widely with our community. So Dr. Moughamian, thank you for your presentation. Alex, would you like to introduce yourself?
Yeah. Hi, everyone. I am Alex Kaplan, and I am the caregiver coach at Institute on Aging. My role is to provide emotional support and resources to family caregivers. Prior to this role, I was working in the senior living industry as a memory care director, and I've been at Institute on Aging for about a year now, and I've really loved my time. And I'm looking forward to going through some slides with you to share with you what we do.
Okay, excellent. So as Alex mentioned, she is part of our Compania team, which is Comprehensive Dementia Services at Institute on Aging. We're a San Francisco-based nonprofit that serves adults with disabilities and older adults, as well as their care partners throughout the state of California. We do that through 4 priority impact areas. And our mission is to enhance the quality of life for adults as they age by enabling them to maintain their health, well-being, independence, and participation in the community. So our 4 priority impact areas are caregiving, alternatives to institutionalization, social isolation and loneliness, as well as dementia. And we're really here to talk today about our dementia services. So this beautiful building located in the Presidio in San Francisco overlooks the main post, has a view of Alcatraz and the bay, view from the parking lot, also can crank your neck and see the Golden Gate Bridge. It's a spectacular location where we provide our adult day program. There we're really focused on providing the person with diagnosis, emotional, social, physical, and cognitive stimulation. Programming hours are 9 to 3. Our staff are dementia certified and create a loving, warm environment. We rotate programming every 30 minutes to engage people, most of whom identify as an individual living with mild cognitive impairment or mild to moderate dementia. Our other components of our comprehensive dementia services include caregiver coaching, of which Alex sees clients both in their homes in the Bay Area and telephonically and virtually. She provides, as she mentioned, practical and emotional support. This is really key in getting respite to caregivers, getting tools and supports. And one of the things you're going to hear throughout our presentation today is the value of the care dyad in taking care of the person who's providing the care. Whether you're identifying yourself as a caregiver or not, we want to make sure that you have the support you need. We also offer a personal concierge service. You can think of this as a white glove personal assistant who can help allow loved ones to enjoy a higher quality of life while we take care of the to-do list. We have care management provided by a licensed clinical social worker. This includes a range of things from medical care management to long-term care planning and social calendar planning and everything in between. And then finally, we have a non-medical home care department called Choreo that has dementia-trained home care providers who can provide services in the home. So we're really thinking about the ecosystem of the person with diagnosis and of the all the services that the caregiver may need. So Alex, I will turn it over to you.
Laura, yeah. And like Laura said, we want to make sure that you feel supported throughout this caregiving journey. And so we have a couple of slides that describe ways that you can seek support and find support. I also would just like to mention one thing that I love about working for Campania is our goal and our full mission to really support both the person with the diagnosis and then also the person who is caring for them. As we all know, the diagnosis doesn't just impact the person who receives it, but also friends, family members, and neighbors. And so with all of this said, I would like to talk to you a little bit about ways you can support yourself. So first step or first slide is engaging community. It can be really hard once you receive the diagnosis to share it with friends and family, but I encourage that you share it with people who you trust, who you know can be supportive to you and help you through this. As Dr. Moughamian was saying, it can be a long journey, right? And it's a progressive disease. And so, you know, if your loved one is diagnosed with mild cognitive impairment and maybe things are kind of okay, it's still time to build that support system and to find people who are on your team who can help you. So yeah, step one, sharing the diagnosis and really just relying on your community. I know it can be really hard to ask for help and ask for support. And I also know that it can be hard for others who maybe you share with them, my loved one just received this diagnosis. It can be hard for them to really know how to help. So I always recommend to clients and to people I talk to give them specific ways that they can help you, right? Give them some tasks they can do, whether it be bringing you dinner once a month or maybe coming over and spending time with you and your loved one, or maybe, you know, maybe kind of watching your loved one so you can go out and run some errands, get your nails done, something that you can treat yourself with. And you can also ask your friends and family to help you find resources. A lot of people who call into Institute on Aging will actually say, you know, when we ask, how'd you hear about us? They'll say, oh, my sister-in-law was doing research for me, or my neighbor was doing research for me, right? So it's okay to ask for help. I know it can be difficult, but people want to help. They just may not know exactly how to in this situation. Any other thoughts, Laura, that you want to add? Or
no, that's great. Thanks, Alex.
Mm-hmm.
The next area we want to just share a little bit of knowledge on is using a formal support system. So Alex gave us an overview of your informal support system and how to draw them in and get more support than you may be receiving today. We also really want to advocate using your formal support system. So documenting your behavioral observations, changes in conditions, time frames. If you're thinking about seeking care, if you're observing things, having an accurate history will help your professionals around you, both medical and non-medical, have a good understanding of how to care for your loved one. We'd also strongly encourage you to make the modality work for you. A lot of in-person activities have resumed. We're very excited. And for some of us, the travel time required arranging a caregiver to take care of our loved one while we're away from the home is too much coordination to allow us to enjoy the activity. So seeking services that allow you to engage in a modality that works best is something we want to encourage you to do. And then we also want to suggest seeking licensed professional support. So every county has an area agency on aging, which can help you find local resources no matter where you live. We also heavily rely on the Alzheimer's Association for some of their support groups, which are open to caregivers. And we host a few caregiver support groups at our enrichment center. in hopes of bringing people into the community, from the community to offer them support in any way that we can. General practitioners can make referrals to gerontologists, neurologists. Again, coming with that strong history is going to help them understand how best to guide you and navigate your care alongside with you. And then finally, I'd be remiss if I didn't put a little plug in for licensed social workers and geriatric care managers who can prove to be a real partner in this journey with you and are readily available. So lastly, we want to just encourage a few mindful tips of how to support you that, when we hear the word self-care or prioritize yourself or make sure you're not pouring from an empty cup, we've all heard those phrases and they're much easier heard than done. So Alex, what are some tips you give to our caregiving coaching clients?
Yeah. So as much as we want to go to a full spa day and be gone from 8 a.m. to 5 p.m., it's not really doable, right? When someone is relying on you for care. So I always recommend, take self-care in small doses, take 5 minutes for yourself, whether it's before they wake up, when there's, maybe at night when they fall asleep, if they're with someone else, like just take those minutes for yourself and be intentional in doing so. So I made a list of a few ideas that you can do. You take 5 minutes. Phoning a friend, if you can, close the door and talk to a friend in your bedroom or in your living room. If you like to bake or cook, maybe find a recipe that you haven't made before and bake it or cook it. Listen to a favorite song if you can and dance. Music is also so great for dementia too, and just the brain. So, make that music loud and you can dance with your loved one as well. Even just enjoying tea and coffee. I know that sounds so simple, but making yourself a cup of coffee and just looking out the window or stepping outside, even just in your doorway, can really go a long way. Looking at photos, maybe family photos, vacation, and photos of vacations you've been on, anything that can kind of take you out of your current situation and help your mind wander elsewhere. And then lastly, step outside, get some fresh air, and try to use all of your senses when doing so.
Thanks, Alex. We have our contact information here. If you'd like to reach Alex, her email address is listed, and you can also call our main number if you're interested in learning more. Susan, I'll turn it back over to you.
I have worked with the Institute on Aging for many, many years as I grew up in the Bay Area, and I cannot thank you enough for the services and what you provide for caregivers. So thank you so much for that. Thank you for joining us again, Dr. M. I'm just going to call you that.
Call me Dr. M. That's fine. I also want to say the Institute on Aging is fantastic, and I agree with everything that they said about the importance of caring for the caregiver. It's great to plug about getting good history, because we always ask you, when did this start? And I usually like to use the analogy of it's nothing and it's nothing and it's nothing and it's nothing, and then all of a sudden you're 500 feet down a pretty big hill and you look back and you're like, oh wow, that's something. So it's these accumulations of these little bits of nothing. Oh, I forgot. I mean, everybody forgets things. I made a wrong turn the other day. It doesn't mean it's a problem. But if it's the wrong turn that keeps happening over and over again, or the appointment that keeps getting missed over and over again, more than what you would expect for them to have done previously, that's when it starts to get concerning. And so making a mental note, creating awareness, destigmatizing this is so important for early detection.
Oh, somebody just listened to our Q&A. They asked to put the slide back up for your contact information. Thank you, Janelle, who's behind the scenes with Finest City Entertainment. Is there an age limit for participating patients?
For lecanemab, the trial included patients from ages 55 to 90. So above 90, we don't know. I would say it's important, particularly on the later stage of disease, to put it into the context of the efficacy and the burden that's involved in doing this treatment. If you have a mild cognitive impairment and you're in your late 80s, this disease is going to progress over 10 years, right? So the likelihood of, I'm just being honest, right? Like your mortality is going up as you are getting older. So the likelihood of you having something else happen to you that probably is completely unrelated to Alzheimer's disease is pretty high. So now I'm not saying that I'm not doing it in older people in their late 80s. I just think it's important that the risk benefit changes. There's an upfront risk, there's an upfront inconvenience of going every 2 weeks to an infusion center and getting MRIs for what's that long-term benefit. And I think your age matters in here. But again, as we're slowing the disease down, but something else may get you. Now, if you're in your early 60s or early 70s, then I think that risk benefit may change. And it's very dependent on the patient. As I said in the beginning, my goal is to open the door and to have you walk into it. But I do think you have to put into the context of your other medical illnesses and your overall quality of life and what you value in your life.
I think it's quality of life, and I can't imagine my mother's 88 and just going every 2 weeks for an hour infusion would be very difficult to navigate that. I could not agree with that more. And you mentioned before that people that are not 65 and on Medicare right now, you can navigate that with insurance. It's just a little more cumbersome.
Exactly. Yeah. And some people maybe even be younger and they say, look, I just don't want to feel sick. I don't want to feel like I'm going to an infusion center, and I don't want to feel like I'm doing that MRI. And that is entirely and they're like, the benefit doesn't really seem like it's worth it. I think that's fine, right? Like you're making that decision. And so my point is, again, like I want patients to get evaluated so that they can make the decision. Because if you wait too long, then the decision is made for you because you're not going to benefit from this medicine.
Exactly. And then can one of the 3 required MRIs in the first 6 months be used as the 1-year baseline MRI?
No. So you do need a MRI prior to the first prior to initiating treatment, and then you need additional MRIs at 2 months, 3 months, and 6 months. So I guess if you're just getting worked up, the likelihood is you probably got an MRI as part of your workup. But if you've been diagnosed for a year or over a year, you probably need you will need an updated MRI prior to initiating treatment.
And Laura and Alexandra, do you have advice for caregivers that suspect their loved one may be experiencing MCI? Like you can see it in them in their everyday life. And I think Dr. M went over really specifically what that means based on subjective cognition and executive decision. That thing of the brain was really helpful.
Don't hesitate to initiate a conversation because you're concerned about the diagnosis. As Dr. Moughamian just said, if you wait, the decision will be made for you and doors will start closing. So as scary as a diagnosis is, it's information that will help us provide the best care and treatment for you during the disease progression. And it's a slowly progressing disease for some people. So just a diagnosis alone doesn't mean it's going to rapidly progress, but it does give us information to provide wonderful care for you and your loved one. Alex?
Probably open more doors.
Absolutely. Alex, did you have anything to add?
I just echo everything that you said. I also think, it depends on the person, but sometimes putting a name on it, like they're noticing these changes, sometimes putting a name on it kind of honestly can provide you some relief. You know what it is now, you know that you can get help, you can have medical professional helping you or whatever type of professional you're looking for. So sometimes just honestly hearing that and having it written down that it is dementia or, it can provide some relief for the caregiver.
And for the patient, I think actually just, often patients are anxious. And this allows you to compartmentalize this thing that it gives you a reason for it to happen. And that, I'll be honest, like the workup process is going to be anxiety provoking. I always say nobody likes being in my office because we don't really talk about pleasant things. But the work you will get, maybe you get a diagnosis you don't want to hear. I can also diagnose you with not Alzheimer's disease, right? So if everybody walked into my office with Alzheimer's disease, that's a problem. I'm not seeing the right patients. I need to be seeing people in this early stage where I can tell you don't have it too, right? So that can be very anxiety relieving. But even if you do get a diagnosis that's not what you would like, you may get more anxious and worried about it, but then you'll realize, actually, this is a slowly progressive disease. I can adapt around this and I can still have a really good quality of life.
I've also heard that it could be some supplements you're taking or interacting, or it could be, certain other environmental things in your life that you could actually control. And advice that was given to me when my dad was inhibiting these signs of MCI was to write it down, just that piece of paper that Alexandra told you to put a name on it. Just write down certain things you're noticing. It makes the visit to the initial doctor a lot easier. One more I have here. If you have concerns about positive cognitive impairment and your doctor says, oh, that's normal, nothing to worry about, but you want to have a more in-depth assessment, how do you start? Where do you go? And I'll just throw that out to the three of you.
I could start with this. I think another positive that's going to happen from lecanemab is that it's going to force the medical community to be a little bit more proactive about assessing people at early stages of cognitive impairment. I would not be surprised if a lot of people go to the doctor and they say, I forget words too. You're talking to like a 60-year-old internist and like, I forget some words too. And that's not in anyone's service. And there's definitely education that has to happen at the level of primary care doctors. I would even argue geriatricians, general neurologists, at improving and taking these concerns more seriously. I think that now that there's quote unquote a treatment, even though there was always a treatment, there was management that we could do. This is going to hopefully incentivize people to earlier diagnosis. That's going to take some time because people have to get educated. And this is a paradigm shift. Right now, what I would tell people that have, it's good. So number one, talk to your primary care doctor. That's your first go-to. If the primary care, and talk to the patient, but sometimes if the patient doesn't necessarily feel they have the symptoms, it's okay to go with the patient to the primary care doctor's office. That also elevates it a little bit, saying, look, I see something that's different. And if you still get dismissed, you have to be dogged. And if you really feel, and that's many of the way that people come to my office is they're like, I just persisted. And then you finally find your way. There's a lot of backup in my office too, just to be honest, and all the other academic centers around. But you do have to be persistent. So I would go primary care, general neurologist. And then if you really can't get there, you're going to have to push. It's going to be a bit of a slog, and it's hard for even doctors to get doctor's appointments sometimes. But it is really important, and you have to try to just not give up.
Mm-hmm. And I would add here, asking for a formal workup, right? Not just whether it's the primary care, the social worker, some baseline level of MOCA testing, anything that can give us some information that says there's been a change. It doesn't necessarily have to be a full workup if the doctor is giving you some pushback, but you can say, okay, then what's an interim step? And I, as a patient advocate, don't take no for an answer. There has to be some workup that can be done. Might not be the most comprehensive, but it is a starting point to give us information to either validate that there is some cognitive change or that this is typical.
I think that's really important. And I would actually parrot those words back. I can't take no for an answer. I'm very concerned and I really need some guidance on this. And you all talked about being an advocate. Take someone with you that's a real tough person. I was going to say something worse, but take someone with you that's, really, assertive in their way. And then maybe they can advocate for you so you're not embarrassed. But thank you so much, everyone. Thank you to our audience. Remember, everybody's going to receive a copy of the webinar to share with friends and family. Today has been such valuable information for everyone. I can't thank you enough for your time. And on the East Coast, have a nice evening. And on the West Coast, have a great afternoon. Thank you so much. Be safe.
Thank you
Bye,
for
guys.
having us.
Bye. Thank you for having me.